We'll go through this real quick because we did this last week. All the V leads are contiguous with each other. The inferior leads, and Grace, remind us, what are the inferior leads?
2, 3, and ABF.
That's exactly right, are contiguous. And Eli, what are the lateral leads?
1 AVL. And
Keep going.
you're right.
Okay, let me rephrase that.
V5, V6.
Good,
For the
okay.
high lateral lead.
Exactly right. So one in AVL, the high laterals.
Don't call me.
Okay. Okay, so here they are, anyway. Okay, so let's do it. Locating a STEMI. So I'm just going to go through all the different kinds of STEMIs that we can have, aside from right-sided and posterior, because we'll do that later. So an inferior STEMI shows ST elevation in at least 2 out of 3 of 2, 3, and AVF. Okay? Typically, the involved arteries are either the RCA, the right coronary artery, or the left circumflex. Because remember, these are the 2 arteries that circle around the back of the heart and drop to the bottom. So even though it's a bit counterintuitive, the RCA and the LCX perfuse a similar area, and that's the posterior and inferior walls of the heart. Inferior STEMIs, it's kind of rare to see just an inferior STEMI. You do sometimes, but typically they are in conjunction with either a lateral, a posterior, or right-sided, meaning that they happen together. So, let's see. Kyle, we'll start with you. I want you to show me where the ST elevation is in the inferior leads.
There's quite a bit in 2 in ABF and a little bit, 3 in ABF and a little bit in 2.
Yeah, so we meet our criteria here of 2 or more contiguous leads, okay? So any questions about this? We're going to be doing lots and lots and lots. This is just the first one.
Kyle, can you point at the J point in 3? 3? Good question. Okay,
Yes,
cool.
that's correct.
Since that's so elevated.
Oh, if you think that's so elevated, if
Right.
you think that's so elevated, just wait. Okay. Okay. So here is another one that is purely, pretty much, just inferior. Why don't you pass that down to Koa? And Koa, can you show us where the ST elevation is?
Let's see. 3.
Uh-huh.
J point. I can't really find the J point. 2. I think it'd be right here.
No, the J point
Or right
in,
here. Yeah, sorry. So
Yeah.
None and 2. Here at 3.
yeah.
And then can we use AVR since it's just upside down too? Or no?
No, don't use AVR on
Okay.
this.
And then AVF Padoom.
Padum, okay. Yes, so we absolutely have elevation in 3 in AVF, and 2 is a little bit equivocal. We don't need it because we've got it in 3 in F, but 3 in AVF. You can sort of see, it depends, is it this one or this one? But it's not, this isn't quite good enough to get us to the cath lab, but this is, okay? And is this a different one? Yeah, this is a different one. Okay, so here's another one. So why don't you pass the pointer on to somebody? So Eli, do you want to show us? This is a inferior STEMI. Just show us where the elevation is, please.
And 2.
Uh-huh.
And 3.
Uh-huh. And?
AVF.
Yeah. So again, these are these sort of slightly irritating J points where they're nice, not nice sharp corners. But I think we can all see that it's somewhere here, so it's clearly elevated. This one is a little bit sharper, so we can see here there's almost 2. And then here, there is an R wave and an S wave, and the J point is right there. So we have three pretty solid. Oh, I did this wrong. Okay. Sorry. Look at your handout.
Okay.
And just forget the last 5 minutes, and I want you to look at 1, 2, and 3 and say whether you see inferior Stemis. Okay? And don't pay any attention to, the hacks in the front row over here. They don't know what they're talking about. Over there. Oh, calipers here. And if anybody wants to borrow a straight edge, I've got about 4 of them, so you're very welcome to. First come, first served. So, anybody else?
Okay. One, two, and three, okay?
Yeah, 1, 2, I'm sorry, 1, 2, and 3, please. How many people are done? Okay. Okay, so number 1, I hope everybody saw, particularly since it was a bit assisted, that they're actually, so when I'm not going to ask people, remember this is the one that has ST elevation in 3, 2, and, not very much in 2, definite in 3 in AVF. Okay, yes, Cody.
So it's not two or just not very?
We can. It's one of those things that we could argue over. Fortunately, we don't need to because we have contiguous in 3 and ABS. So we've got enough here that gets us into the pathway. So what I'm going to say over and over and over again, many times throughout these classes, if this mattered, let's say it all looked sort of like this instead of like really clear ST elevation, but if it was sort of equivocal and we're sitting there going, is this ST elevation? I'm not sure. First of all, there is other stuff here that will help you, but we're not there yet. But one thing you can always do and should do is serials, SERIAL, 12 leads, okay? You can get reasonable 12 leads as you're going down the road. So do a 12 lead unseen, and as Riley said, we're loading and going, so we're going, but leave the V leads, the electrodes on, replug them in when you get in the back, and then it's easy. You just keep pushing the button, and it spits out another one. And what we're going to see, and I'm going to show you plenty of examples, is how things can change. So if you have ST elevation you're not sure of, check in 10 minutes, see if it's changed, okay? But this one's pretty clear because of 3 in AVF. Okay, and then 2 we also talked about, so we have 3 good leads of ST elevation. Everybody see it? Okay, Natalie, what about number 3?
I did not see any.
Nope, no ST elevation here, so no inferior STEMI here. Okay, everybody okay with that? Okay, moving along to septal. V1 and V2 are the septal leads. Shows ST elevation, septal STEMI in V1 and V2. the involved artery, no surprise, the left anterior descending goes right down the front wall of the left ventricle, goes right over the septal wall. It's very rare to see just a septal STEMI, okay? Typically, it's in conjunction with an anterior MI. In fact, I really couldn't find one. So if we look at this one, who's got the pointer? Okay, Spencer, so in the V leads, where do you see ST elevation?
In the septal leads?
So which leads? Point to which ones you see.
That one and that one. So
Okay. V1.
The J point, V1, J point's like right there.
Uh-huh.
And those are pretty far off, so I'd say that's elevation. I do have a question. Do you care if it's only present in one of the complexes, or I mean, if you see it in one,
Well,
you're gonna see
here
in
it
the other
is. Well, if you only see it, let's say you have 4 complexes, you only see it in one. I'm just doing it on problem, see what I see.
one? Okay, cool.
Okay. So V1 and V2, where else? There is another lead that has ST elevation. Another V lead. It's a very weird looking lead, which is part.
Say it one more time.
It's a little weird looking, but there is ST elevation. Which one?
Gosh.
Yes, V3.
Okay, cool.
Okay, so what's happening here is, well, what is happening here? So you can see the R, it's easier to see here, there's, the R wave goes up, and then there's almost a little tiny sort of negative deflection, and the S wave and the J point's right here, okay?
What about 4? 4 looks like it has.
Oh,
some too,
excuse
right?
me, you're right. So 4 as well. So
Okay.
my bad there. So so if somebody says to you, what kind of STEMI do you see? The answer is septal anterior, because there's ST elevation in the septal and anterior. Now there's all kinds of different ways that you will read this. You will read septo anterior, one word, anteroseptal. I don't care. What I just do is I just stack up the words. Okay, septal, anterior, and that works totally fine. If you want to sort of push them together, be my guest. But I think the easiest, clearest way is when you see multiple areas, just list the areas. Okay, Brandon, what are the anterior leads, please?
The interior would be 3 and 4.
Correct. Okay. So anterior STEMI shows ST elevation V3, V4. Again, the involved artery is the left anterior descending, right? Anterior, left anterior descending. Goes right down the anterior wall. Almost always occurs in conjunction with either a septal and or a lateral. Yes, Grace.
Do you want us to know which one it usually is in conjunction with, or because we're going to be checking it all?
I think I'm okay if you just allow that to develop organically, because it will. Like one of the really common, which you'll see over and over again, is inferior lateral and posterior, inferior posterior lateral. You'll see that over and over again, and it'll be very helpful for you to know that. But I think you're going to be looking, and I'm going to be pointing out and saying, look, here it is again. So if you're asking, is it going to be a test question? No. Only that specific part. All the rest is fair game. Okay? Okay, who's got the pointer? Okay, so tell us where you see ST elevation. It's going to be in the V leads. We're not caring about the limb leads right now.
Okay, question.
Yep.
Is this in our handout or?
Oh, is this another one of those? Oh, right. Thank you. Okay, so what's that?
I'm confused. Is it in the handout?
It is in the handout.
Oh.
Okay, so look at 4, 5, and 6. For some reason, I can't seem to get this straight today. Look at 4, 5, and 6, and tell me if you see a septal anterior STEMI. Before you do that, let me answer a question I know that is coming. If you see ST elevation in V1 and V2, and a FOF, V1 and V2, what kind of leads are those? septal, and V3, because remember V1 is contiguous with V2, is contiguous with V3. And Koa, what kind of lead is V3?
Anterior.
Interior. So you see elevation in V1, V2, and V3. I know the question is going to come, what do we call this? Because there's 2 septal leads and 1 anterior lead. You call it septal anterior. Okay, if it's a septal STEMI that spills into the anterior, just pull the name along with you. Okay? So 4, 5, 6, please. Yes.
Kind of behind the
Yeah.
question, but so when we're measuring for ST elevation, are we measuring from the J point?
Yes.
To the top?
Isoelectric line.
J, okay, understood. Thank you.
Yeah, and what that means, and that's where your straight edge comes in, is you have to find the isoelectric line, and which sometimes is really easy. Like this one is pretty easy, it just goes across, and sometimes it's really
I mean, you see the other one. Well, I've had a lot of money for you, so I'm freaking out.
Yes, you're just looking for septal anterior. If you don't see a septal anterior and you happen to see something else that you know, you might as well jot it down because I'm going to ask you.
Okay. Patients having a massive heart attack. It's not septal anterior, it's
Not simple anterior. Fine. Monitor says you're fine, so. I'll still,
And profile.
Oh, sorry, I'm holding up. Do you want it? Everything. No.
How many people are done? Okay. Okay. We've been sort of vaguely moving along in a line. I don't know who's next. Okay, Riley, what do you got here?
Looks like there is elevation in 1, 2, and 3. V1, 2, and 3, excuse me.
So V1, V2, V3.
That's correct.
Okay.
Yes.
And does anybody remember what's the trick with, you're correct, what's the trick with V2 and V3? How much elevation do we care about in V2 and V3?
1.5 point.
Yeah, 1.5 to 2, okay, and we have it here, so, okay, so what do we call this?
That is a septal anterior.
Yeah, it's a septal anterior STEMI. Did anybody say there is elevation in V4? Yeah, I think there's a tiny bit there as well. It doesn't change our septal anterior designation, but yeah, I think there is a bit, okay? Questions about this?
Yeah.
Yeah,
It has nothing to do with ST elevation.
Yeah.
Would you consider those peak T waves?
probably more likely, and we're gonna be talking about this in about 15 minutes, I would consider them hyperacute T waves.
Okay.
So,
Slow it down, bro.
okay, who's next? Who's next? Who's next? Okay, Brandon.
I didn't see anything on this one.
Okay, so no elevation in the septal anterior leads.
What do you see, what does depression tell you though? We'll get there.
Nothing right now, but it will soon. We'll get to it, okay? Okay, so Brandon is correct. There is not a septal anterior STEMI. Are you gonna take this patient to the cath lab?
Yes.
Why? What do you see?
Inferior.
Yeah, and that's not what I was asking. but there happens to be ST elevation in 2 and 3 in AVF. If you didn't see it, that's okay, because I know you're just focused in on the V leads. But we can't let it go by. Okay, number 6, who's next?
That's me. I said I saw a little bit of elevation in V1, definitely V2, definitely V3, a little bit, or yeah, in V4 as well.
Okay, so if I said what kind of STEMI is this, what's your answer?
Septal and
Septal anterior, okay? And then we're going to go back because I somehow have been a little confused this whole lecture about what, we actually did not talk about this one. So who's next in line there? Okay, Grace, can you see it from here? You don't have it on your handout.
we don't have that right now?
Not this one. This was one that just came before that got lost in the shuffle.
See some there,
Uh-huh,
there.
uh-huh. And I would put the J point right there.
Okay, so yes.
Okay, so where do you see ST elevation? Can you summarize it, please?
V1, V2, and V3.
And what kind of STEMI is this?
Septal anterior.
Correct. Now remember, I understand that there, first of all, we have 3 contiguous leads. And I do understand that 2 of them are septal, so that's easy. There's only 1 anterior. But the convention is, because it spills into the anterior area, even if it's only 1 lead in the anterior region, we call it septal anterior. Now, there are some references that, just to let you know, we are definitely going to make a distinction between septal and anterior. There's some references that don't. They just call V1 through V4 the anterior leads, okay? But we're just going to go with V1, V2, septal, V3, V4. But think of it, it's just one big contiguous strip across the front there. Okay, so, okay, moving on. Lateral shows ST elevation in 1 AVL, V5, and V6. I say at least 2, and typically you'll see them in either 1 in AVL or V5 and V6 if you only see 2. That's just how it works out. The involved artery usually is the left anterior descending, but also the left circumflex can be involved. Can occur by itself or with anything else. So, okay, who's sort of next in row here? Where do you see ST elevation? Whoever's doing this one. And if you can't see it, you do not have this on your handout. So, if you're having trouble seeing it,
I'll give it my best go.
Okay,
So I see it in 1.
good,
I see it in ABL as well.
good.
So now we're going 5 and 6. I definitely see it in 5. And I see it in 6 as well.
And where else do you see it?
So like all over.
Okay.
You have an all over.
2, 3. I think you're trying to screw. So I see it in, let's see, that'll be 4.
Good.
I see it in 1 and 2, or no, sorry, 2 and 3. I
2
see
and
it in
3.
ABL, I already said that. You mean
Okay.
V2?
Okay. So, do you see any in V1?
Yeah.
Okay.
Right.
Do you see any in V1?
V1, no,
V2?
yes,
V3?
yes,
V4?
yes,
V5?
yes,
V6?
yes.
Okay. So, what do you think you would call this?
Septal anterior lateral.
Bingo. Nice job. Yes, Natalie, please.
For laterals, when we're naming semis, do you have to differentiate between high lateral and precordial lateral? Is that more just a?
No, and in fact, no, you don't have to. The way I think it's useful, the reason I think that distinction is useful, but you're not required to do it, is that it's pretty common to see 1 in ABL, but not V5 and V6. And so it's really useful at that point, especially when you're thinking about it, that these are lateral, oh, it's a high lateral STEMI, but you're not required to do that. I think it just is a nice way to organize it in your mind. Okay, now, on your handout, 7 through 9 is there a lateral STEMI. And if you happen to see anything else, go for it as well. Okay, who's next here? Okay, what do you see here? Sorry, there you go.
I mean, nothing's better than Stemis, but yeah.
So 1 in ABL, I don't see any elevation, but in 5 and 6 I do.
Okay, so 5 and 6.
And I also do see it in the interior.
Okay, so how would you say that?
Inferior laterals?
Yeah, inferior lateral. Okay. Now, I've done you a little bit of a disservice by having you practice in the way that you have, and I was sort of sitting here going, oh, I couldn't have done that. When you go through a 12 lead, you know, what I'm having you do is practice, but I'm saying look for a lateral, so of course you go for the lateral leads. That's fine for this exercise, but it's kind of bad technique. So what I'm going to say is from now on, when you're looking at a 12 lead, the best way to do it is to look at lead 1. Is there elevation or depression? Look at lead 2. Is there elevation or depression? Lead 3. Go through all the leads. And if you have them on paper, which you should, what I usually do is I label them with an E or a D, okay, like that particular lead. So for now, it's fine because I'm just having you practice a little bit. But again, it's better to be a little more systematic than this particular exercise is guiding you to be. Okay, that being said, number 8, please.
Okay, I see elevation in 1
Mm-hmm.
and in ABL
Okay.
and B2,
Mm-hmm.
B3, B4, B5, and B6.
So what would you call that?
Septal anterior lateral.
Perfect. Questions? Okay, final one here.
All right, so I see elevation, ST elevation in V1, V2, V3, V4, V5, and V6.
Correct. So what have you got?
Septal anterior lateral.
Yep, yep. Okay. So questions? Yes, please.
Is there like a little bit in ABL or?
Yes, there is. And it's, again, yes, there is. So, yeah, yeah.
Will we ever see elevation in every single lead except for ABR?
Yes, and it's not always because of a stem. But you can. I mean, you can have these absolutely massive stems.
And that's just like all over is
All over.
going whack.
Gone. Yeah.
Would a massive STEMI be like 2 regions, or what would it be, like the definition of a mass?
This is pretty massive. So, I mean, if you think about it, this is like, you know, practically the whole left ventricle. I think what you're asking is for, is there a specific definition? And I don't actually know how many regions it takes, or I suspect, I'll check on it, see what I can find. I suspect that it's more has to do with how much function is left. So you remember when we talked about ejection fraction, we said, oh, anything below 40% is cardiogenic shock. So my guess is it's not measured by regions, it's measured by function. So, but I don't know what the definition would be, or if there is a formal definition. I'll see what I can find out. Okay, so again, you guys are doing great. It's nothing like a little practice to really start remembering where everything is, but don't slow down. By next week, this should be like, yeah, piece of cake. Okay, I know that some people have said, and also based on the questions I'm getting, I know that some people are aware of, some people have said they've done a little bit with 12 leads. So let me ask you a nice leading question. Are STEMIs the only reason for ST elevation? Even if you have the least little bit of test-taking technique, you can answer that.
No.
So no, of course not. So there's what we think of as the mimics, and we will be getting into, not today, but a big one is left bundle branch block, pericarditis, something called early repolarization. The old name is benign early repolarization, left ventricular hypertrophy. All these things that are going to make your life miserable. Okay? And so what that means is that, at this point everybody thinks, oh, I've got it, 2 or more leads of ST elevation and we've got a STEMI. For a lot of the ones that we looked at, these were the ones that jump out at, I cherry picked them of course because we're just starting off, the ones that really jump out of the page at you. But there are other pieces of evidence that you can accumulate, and will be expected to accumulate in this class, to say, yes, this is a STEMI. This is not a mimic, this is a STEMI. And we're going to be talking about these a lot, but we're going to start today. The 3 big ones I want you to know are reciprocal changes, hyperacute T's, and pathologic Q's. I don't think I meant to do it this way, but these are set up in order of importance into how much weight they give your identification of a STEMI. Reciprocal changes are the gold standard. In a way, almost even more than ST elevation, but certainly in a combination with ST elevation, if you have ST elevation and reciprocal changes, you're golden. It's straight to the cath lab. So reciprocal changes, and I think you'll feel this more and more as time goes by, are so much your friend, okay? Because they just solve every problem in terms of identification. Hyperacute T's are really interesting. You won't see them all that much. And pathologic Q's, and I'll tell you why when we go through them, are sort of useful, but not nearly, say, as useful as reciprocal changes. But again, I'm introducing all of these as further evidence of a STEMI. Reciprocal changes occur when you have leads on the opposite side of the heart from the leads that show ST elevation, okay? So, for example, in a minute we'll look at a picture. When there's an inferior STEMI, meaning that we have ST elevation and 2-3 AVF, or 2 of those 3, then you want to look for ST depression, which we're also going to call reciprocal changes. The depression is the reciprocal change, in 1 and AVL. So, what's all this about? Here is 2-3 AVF, and here is 1 in AVL. And they're not directly across the limb lead circle, but they're sort of across from each other. So what that means is if your patient has an inferior STEMI showing ST elevation here, very frequently you will see ST depression here. It does not mean there's a problem here. It's a reflection of the damage that is occurring here. And the great thing for you as the 12 lead interpreter is if you have ST elevation here and depression here, you have nailed down, absolutely nailed down an inferior STEMI. Yeah.
So it's very similar to like 2 and AVR. It's kind of the same thing.
Sort of. Although, it is, yes, it is. I'll just say yes and not go into the differences. But yeah, it is similar. It is actually similar. Okay, so here's our little chart. Is ST elevation here, reciprocal depression here, the high laterals. Okay, not here, it's the high laterals. That's one of the reasons why having the distinction of high laterals is useful. Okay. Okay. Do we have ST elevation in the inferior leads?
Yes.
Yes, we do. And then you look, your automatic thing is to look, although you've probably gone through it and you've labeled everything, is there ST depression in 1 in AVL? Yes, there is. We call those reciprocal changes, okay? So if you were calling this in, if you were interpreting this for the charge nurse, for example, you would say, I have a patient, blah, 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 with, 2 to 3 millimeters of ST elevation in 3 in AVF and reciprocal changes in 1 in AVL. And then we'll open up the cath lab. Okay? Yes?
Are you looking for the same amount of depression as
No,
elevation?
no.
That doesn't
Doesn't matter.
Okay,
Doesn't
cool.
no. In fact, and not only that, it can only be it's still considered reciprocal changes if it's only AVL.
Okay.
or
so
only
just gotta
one.
confirm it in one of
Yep,
them.
only one will do it. Yeah.
Alright.
Okay. Now the opposite is true for reciprocal changes. Not all well, I'll just start with this. When there is a high lateral STEMI, so Brandon, high lateral STEMI, which leads are those, the high laterals?
Is it 1 and AVL?
Correct. So in 1 in AVL, look for ST depression in 2-3 AVF. So it's just the opposite of what we just said, okay? Sometimes that's in italics because it's not common. You don't need to know that, but it's there if you want it. Okay, so again, they're still across the circle from each other. So if the ST elevation is here, then you want to look for the reciprocal changes here. It's just the opposite. Okay? So what we're having is elevation here, depression here. Okay? Okay, so we have ST elevation in 1 in AVL and reciprocal changes in 2-3 AVF. One of the great things about reciprocal changes are in this, here's a great example. In this particular case, okay, here's our isoelectric line, here's our J point. There's no question there's about 1.5 millimeters of elevation here. That's pretty solid. Here, yeah, just barely 1, okay? And so, cath lab probably, add reciprocal changes, definitely, okay? Reciprocal changes are a great way if you're a little confused. Is that enough elevation? Oh, reciprocal changes, we're hoping.
Say you had like elevation in 1 AVL, are you looking for like reciprocal changes in all the other leads, or
No,
are you
just-
fine with just one reciprocal change?
When you say all the other leads, you mean all
Like
the
say like
inferior
let's just say
leads?
you only have reciprocal changes in like lead 2 or lead 3, but not in like 2 or AVL.
You're really looking, one will do it, but what you're going to find is it happens in certain patterns. So if there's a high lateral STEMI, it's very common to have elevation depression, reciprocal changes 3 AVF, maybe in 2, but rarely just in 1. It happens. However, if you have ST elevation in 2-3 AVF, so you look at 1 in AVL for the depression, it's very common to have depression here but not here.
Okay.
In which case, it's still good.
Okay.
Yeah. Yeah, so here's what I'm showing you is, oh yeah, it's barely a millimeter. Yeah.
If it's like borderline elevation and borderline STEMI?
It's hard to answer without, I don't consider this one borderline, by the way,
Yeah,
because,
just
yeah,
hypothetically.
but generally speaking, it sort of depends. I mean, it depends on, it depends on if the pattern is there. So for example, if you're, we're definitely gonna be seeing, in a minute, we're gonna be seeing, if the pattern really suggests a STEMI, what one option, there's a bunch of ways you could treat it. One way is to start code 3 towards your cardiac hospital, do another 12 lead in 10 minutes. And if nothing's changed, then call it, okay? But it's also very possible something will change. So it's hard to answer that without the specific 12 lead, but we're going to be seeing plenty of borderline ones where we can talk about it. Okay, so what I want you to do, I'll tell you what let's do is, I want you to go to your handout and look at number 1, 2, 5, and 7. And let me see exactly what I wanted you to do there. Hold tight. 1, 2, 5. And find the reciprocal changes. And I'll tell you what, let's do this. Let's say we'll convene at, right at 10. That'll give you enough time to do it and get a little break, because people are looking kind of restless, okay? So finish it up, take a break, or take the break and then finish it up, and 10 o'clock.
Slash assignment.
We're starting back a little bit early, but everybody's here. Before I forget, there are still 7 people who have not taken the ECG identification quiz, all of which is good, no problem, as long as you're done by 11:59 tonight. It's the last, and that doesn't mean you can start at 11:58. It shuts down at 11:59. Okay, if anybody still doesn't know what the consequences are, all I can tell you is go back and read yesterday's announcement, okay? So please, everybody who's taken it has done great. So those 7 people, jump in. Okay, who's next on our line? Okay, so number 1, what I want you to do is say, is where the ST elevation is, where the reciprocal changes are.
The ST elevation is in 2 and 3 and AVF, and the depression is in AVL and 1.
Okay, so if I said to you, excuse me?
Oh, so therefore there are reciprocal changes.
Correct. And if I said to you, what kind of STEMI is it? What would you say? Inferior, great. Okay. So just to reiterate, what that means is the infarction is in the inferior wall. There's no problem in 1 in AVL. That depression is a reflection of the damage in the inferior wall. Okay, Faf, number 2.
Along the same lines, elevation in 2, 3, and AVF, and then reciprocal depression minimally in AVL.
Correct. In AVL, and I'm going to push back a tiny bit, because if you see the actual, for 2 reasons. One is that I think there's a pretty solid, here's the J point. So there's at least 1 box of depression. But the other thing is, as you're going to see, the more and more you see the reciprocal changes in 1 in AVL, you're going to be happy with just a little bit. So, but anyway, definitely here, and we'll leave it at that. Questions?
Yeah.
Yeah.
There's a little bit of depression in ABR. Would that make you think about doing a right-sided?
No, because you would, in fact, you would definitely do a right-sided, but nothing to do with AVR. It has to do with, as we'll learn, is right-sided are almost always in conjunction with inferior.
Okay.
So you would look for a right-sided, but because of the inferior.
Okay.
Yeah. Okay, number 5.
So there is ST elevation in the inferior leads, and then in lead 1 in ABL, it's very, very small. But I would say, yes, there's
Yeah.
reciprocal depression.
Yeah, there is. Okay. And so what kind of STEMI is this?
This is
Where's the elevation? Which leads?
in the inferior and the lateral, so inferior lateral, let's say.
So wrong. No, I no way to sugarcoat it. The inferior is correct. Okay, and I understand why you say lateral, but when you see reciprocal changes, it's a reflection of the inferior STEMI. So what it does not mean is that there's any kind of damage in the lateral wall. It's a mirror image of this. So this is where the STEMI is, and this simply supports the idea that it's an inferior STEMI.
So just inferior STEMI with reciprocal changes.
Perfect, that's excellent. Okay. Yes?
Also, the question on B2, what does that mean?
I'm going to hold on to your question, okay? If we probably will get to it today, if not next week. It's a possibility, I'm just going to say right now, it's a possibility of a posterior STEMI, but yeah, possibility of, okay? Okay, who's next? Okay.
We'll go inferior STEMI and 2, 3 AVF, and then you have depression in AVL and some depression in 1. So there are reciprocal changes from the inferior STEMI and the high lateral. And is this the same too? Goes for, since this is a lateral STEMI with these ones, these depressions?
No, that's
Okay.
something else that we'll get to. That's the posterior. We also, by the way, do have a lateral STEMI because of 5 and 6,
Yes.
right? Which I didn't ask, but you know. So what you would say is that there's an inferior lateral STEMI, and if somebody says to you, like me, what's the evidence? What you would say is the evidence for the inferior STEMI is ST elevation in 2-3 AVF. The additional evidence is reciprocal changes in AVL. The evidence for the lateral STEMI is ST elevation in V5 and V6. And then pretty quickly we're going to talk about what this is, but not quite yet. So just hang on for that. Okay, so one thing I'm going to say is reciprocal changes only works, you might have noticed this, in some leads. So for example, there really is not a good lead on the other side of V5 and V6. So we just don't have reciprocal changes if there's a lateral STEMI in V5 and V6. There just aren't reciprocal changes because we don't have the leads in the correct placement. So reciprocal changes work terrifically with inferior and high lateral, but we just don't have reciprocal changes everywhere. Okay? So, again, the whole point of this slide is to talk about further evidence for STEMI besides ST elevation. We've already talked about reciprocal changes, so now we're going to talk about something called hyperacute T waves. All right, trick question, although not really if you remember medical terminology. Hyperacute, what does that mean? Okay, well the hyper, everybody always knows what that is. It's right, big.
Yeah.
So do you think this means extra big T waves?
Big, small.
Wrong. What does acute mean?
Quick.
Quick. Like, right, an acute problem is something that's happening now. Hyperacute, although hyperacute T waves do tend to be large, but that's not what the term hyperacute means. It means extra extra quick, extra soon, okay? So that's what hyperacute means. They're called that because hyperacute T waves, which you don't see all that often, and the reason you don't is they may be seen in the very early stages of an evolving STEMI, very early. That's what hyperacute means, very early, hyper early, okay? Frequently missed because they only last a short time. They may only be there for about 20 minutes. And if you don't come and do a 12 lead within that 20 minutes, you're not going to see them. They are bulky, wide, and frequently tall T waves in the infarct area. Okay, so if you have a septal anterior STEMI, if there are hyperacute T waves, and they're not always, but if they are going to be there, they'll be in the septal anterior leads along with the ST elevation. So they're, unlike the reciprocal changes, they are seen in the area where the problem is, where the infarct is. Now, over time, we're going to develop the idea of hyperacute T waves because there are various definitions of how we define, in terms of ECG measurements, hyperacute, okay? So this is the one we're going to start with, and then in a few weeks we're going to develop it further. But this is the one we will start with, is we think of hyperacute T waves if they are greater than 10 millimeters, 2 large boxes, in the V leads, or greater than 6 in the limb leads. And I will tell you now those numbers are a little arbitrary, like all these kinds of numbers are, a little bit arbitrary. Not measured from the isoelectric line, but from the J point. And you'll see what I mean when we look at a picture. So, the hyperacute T waves, when I say measure from the J point, here's the J point here. So about how many millimeters is that particular T wave from the J point to the top? Remember, each large box is 5 millimeters.
Like 15.
How much?
15.
Yeah, I was going to say 13-ish, but we're close, okay? So, yeah, I guess 15-ish is good, okay? And what about this one measured from the J point? Yeah, right on. So the ones that absolutely fit our definition of hyperacute T's are these, not quite these, and this one, if you measure from the J point, not so much. Okay? Now, let's take a step back for a minute, and Riley, if you could, just based on what you see, okay, just kind of go through the leads and say, like, lead 1, is there ST elevation or depression? Lead 2, is there ST elevation or depression?
Okay. Oh, that's funny. With the laser. 1, looks like there's a little ST elevation.
Good.
2, let's see. This is kind of weird, actually.
It's, I know you don't have a straight edge, so it is a little
Yeah,
high.
I mean,
So
it looks
just
like
do your
a-
best.
Might be like marginal depression.
I agree.
Yeah. 3, depression for
Good.
sure.
You can skip AVR.
AVL, ST elevation, AVF, depression,
Okay.
B1.
I'm going to help you with that one and say not much of anything.
Yeah, nothing going on there. Let's see, ST elevation in B2.
Okay.
Can you have ST elevation and a hyperacute T wave or no?
Yes.
Okay. I might be a little hyperacute potentially. This one.
Just for now, just you. I appreciate that you're doing that, but right now, just elevation and depression.
Okay, just elevation.
Yep.
B3. It doesn't. I
Nope,
mean,
you're right. The J point's right on the isoelectric
Yeah, so
line.
there's no elevation.
Yep.
And then B4, no elevation. B5, no elevation. B6.
Yeah.
Yeah, maybe
Okay.
a little bit. Elevation.
Okay. So, so Spencer, looking at that, is there enough information there to go to the cath lab? Is there a STEMI? And if so, what is it? Do you have ST elevation in 2 or more contiguous leads?
Yeah,
Which ones?
just off the bat, you've got in leads 1 and AVL.
Good. Okay, so 1 in AVL, and what do we call that? What kind of?
Inferior lead underneath, so it's gonna be the one.
Help them out. What is it?
Lateral.
Lateral. Okay. And so if you were to say to me, there's a lateral STEMI here, and I say to you, what's the evidence? Initially, you would say, well, I have ST elevation and 1 in AVL. Is there further evidence for the lateral?
Yes.
What is it?
You can see reciprocal depression in the inferior leads.
Yeah, good enough right there.
Okay.
Okay, so we definitely have, so this is a cath lab patient, right? Everybody in agreement?
Yeah.
Okay. Now, just for the sake of the argument, let's ignore that. Let's ignore the limb leads for the moment, okay? I understand we're already going down the road, code 3, okay? But just for the moment, let's pretend the limb leads aren't there. What about the precordials? What about the V leads? Is there enough ST elevation there to open up the cath lab? Correct. And why not? I mean, I see some ST elevation. Look at V2.
Yeah, but there's no, not consecutive, what's the word?
Contiguous.
Contiguous
Perfect.
elevation.
Yeah. However, what you have are the hyperacute T's, right? And everybody understand this is a hyperacute T, this is a hyperacute T, this is almost a hyperacute T, right? So we've got hyperacute T's definitely in 2 contiguous leads and maybe in 3. Everybody see that? Okay. Now, hyperacute T's, at what point do they happen in an evolving STEMI? At the very beginning. So here's my argument, is that, again, we're pretending this is all good over here. It's not good, but we'll pretend it is, okay? If all you had were the V leads, there truly is not quite enough to open up the cath lab. But there is absolutely enough code 3, cardiac hospital, do another 12 lead really quickly. Because the thing about hyperacute T waves, this is going to look like this quickly, okay? So if you know that that's what it is, if you know that, I mean, this is an excellent example, one of the best examples ever, okay? And in fact, in a different lecture, I come back and we talk about this more. I'll show you what happens. It should be in this one, but it's not. But in fact, within about 10 minutes, it's there, okay? So in this case, again, not quite cath lab materials, but definitely enough to get going and look quick, okay? Make sense? Okay. Let's look at some more. So in this particular case, if we look, and I think you may have already even looked at this one, there's no question. There's plenty of ST elevation here, right? Anterior septal, it's there. But in addition, there are hyperacute T's. Do you need these hyperacute T's to confirm the STEMI? Probably not, because you've got so much ST elevation, but this is what hyperacute T's are. Now I think, Kyle, this is the one was this the one you asked? I think it might have been whether these are.
There's a different one.
Oh, okay. The difference, because it is kind of pointy, is that the hyperacute T waves tend to be bulkier, sort of wider at the bottom. Now, hyperacute T's, by the definition we're using today, greater than 10 millimeters in the V leads. What do they have to be in the limb leads? What did I say? 6. Okay. The V lead hyperacute T's are going to jump out at you because 10 is big. The limb lead ones you're going to have to really look for because they just don't appear that big. But if you look at this, measured from the J point, it's greater than 6. Okay, so those are also hyperacute T's.
Okay.
Yes?
In one of the examples that you had in the packet, there are some pretty large inverted T waves. Does it apply to inverted T waves
No.
as well?
No. Okay. I'll just leave it at no, and we'll come back to that. Okay. Q waves. What is a Q wave? Grace, which part of the QRS is a Q wave? How do you define a Q wave? The first what? Negative or positive?
Oh, the first negative
Deflection. Yes, okay. So the first negative deflection before the R wave, unless there is no R wave, and then it's just the first negative deflection, okay? Now, Q waves can be considered normal, sometimes called physiologic, or pathologic. So they can be considered normal or possibly diseased, okay? Small Q waves, and typically the way that we distinguish when we're writing between small normal Q waves and big pathologic Q waves is small we use small q and large we use capital Q. That's pretty standard convention and it's handy. Okay, large Q waves are considered pathologic or at least possibly pathologic. Okay, so that begs the question, what's the difference between small and large? So, and we'll see a picture in a minute because it's hard to figure out exactly what this means. We think of a Q wave as a large pathologic Q if it is greater than or equal to one small box wide at the top, we'll look at a picture in a minute, and or greater than 25% of the total QRS amplitude, we'll look at a picture in a minute, and or greater than or equal to 2 millimeters deep. So what does all that mean? The first one isn't wide. We look at the top of the Q and just measure across from the beginning of the Q, just straight across, horizontal line straight across. And if that between here and here is greater than or equal to one small box, we consider that abnormal. We consider that too large. And or the other measurement is if you measure the total amplitude from the very bottom to the very top of the QRS, and then measure the depth of the total Q. If this is greater than or equal to 25% of the total, that's too large. And then finally, much simpler, is the Q wave greater than 2 millimeters. Okay, and it doesn't have to be, it just has to be one of those. Okay, now I said that Q waves are only minimally useful to us, even though we're spending all this time talking about them. And here's the reason. Pathologic Qs, meaning great big Qs, they don't always, but they may develop during a STEMI, and they typically are kind of the last thing to happen. So, maybe we'll have hyperacute Ts, then maybe we'll have ST elevation, time goes by, a couple of hours, and then you start seeing these big Q waves develop. Okay? The earliest that pathologic Qs develop is 2 to 3 hours after the start of a STEMI. A lot of times you'll read 4 to 6, but the expert that I use as our reference in this class is a guy named Dr. Amal Mattu, and we'll be seeing a lot of his videos in the future. So not all STEMIs develop like this, but this is a possible development. In this particular case, so there are no hyperacute Ts in this particular case, but this is another way things can develop. Here's normal, then things start to go bad, and in this case, the T waves flip over, okay? And then we have some ST elevation happening, then more ST elevation and more ST elevation, and a Q wave starts developing, and more until we end up with ST elevation and a pathologic Q. Now, here's your patient. Let's say this is what we're seeing in the septal anterior, well, let's say the inferior leads. They have an inferior STEMI. You take them to the cath lab, and 6 months later you get them again, and you look at their 12th lead. At that point, the ST elevation will almost certainly all be gone. the guy went to the cath lab, he's now eating, fruits and vegetables, he's running every day, everything's good. But there's a very good chance that the pathologic cues remain. They're like a scar, if you think about it. Doesn't mean at that 6-month point, if the ST elevation has gone away, that there's any problem. It's just a reminder. It's just a scar of the old STEMI. So, frequently pathologic cues remain after the rest of the ECG returns to normal. Okay? This means that pathologic cues can indicate one of two things. And that's why they're not so useful to us as some of the other stuff. They can either say, there's a STEMI happening right now that's at least 2 to 3 hours old, or they can mean this guy had a STEMI 20 years ago, 6 months ago, 5 years ago, we don't know, indefinite age, okay? So how do you tell the difference between a cue that means happening now as opposed to happen once? Okay, here's the answer. If you see a pathologic cue, and by pathologic cue I mean big, by our definition, that's what pathologic cue is. If you see it with no accompanying signs of acute injury, the pathologic cue is just out in the middle of the field with nothing else, no ST elevation, no hyperacute T's, nothing, just the cue by itself, then almost certainly it's a sign of an old MI. However, and what the 12 lead will say is this really sort of cryptic statement, MI, age indeterminate. But it's true. We don't know if it's 5 years old, 2 years old, 6 months, whatever. Okay? Here's an example. I'll help you out here and tell you there's no ST elevation and no real depression either. Are there big Q waves? If so, which leads are they in? 2 and 3. Okay? So 2, 3, and AVF as well. That's that's kind of wide. So what do you think that means?
History.
Of what?
Previous inferior.
What? And it's an old, almost certainly it's an old inferior STEMI. Okay?
Kate,
Yes.
are there ever reciprocal changes?
They go away.
For the reciprocal changes go away?
Yeah. If the reciprocal changes were there, then I would treat it differently.
Okay.
Okay. Oh. So you can see nothing much. Okay. Okay. So no signs of acute ischemia. These pathologic cues are signs of an old MI, age undetermined. Looking a little bit closer, it's the same 12 lead, just blown up. However, if the pathologic cues appear in the same areas in ST elevation, then it's likely that the STEMI is about 3 hours old. Changes nothing in our treatment. So in this particular case, I would actually, if somebody says, so we have a septal anterior STEMI, and if somebody asked me what the evidence was, well, I would say, well, ST elevation in V1 through V4, sort of borderline hyperacute, not so much the hyper T's, but I would say the Q waves are evidence of this STEMI that's happening now because it's in conjunction with the ST elevation. Okay? Okay, so last worksheet, I think. Yes. So 13 through 17, all of the 12 leads have large Qs, so answer the question for each one. Are they probably a sign of something acute or something indeterminate? Yes.
On that continuum we saw when the T wave flipped, does that mean the repolarization is not going in the opposite direction?
I'm not sure. So I will tell you that I'm just going to kind of scoot out from under the question. So T waves are what's called, they're very labile. It's the term that's used, meaning everything affects them. Like they're not, seeing a flipped T wave with a few exceptions is not actually that useful for us because it can mean all kinds of different things. And so whether that's because, it makes sense to me that the repolarization would be going
And over here
in
too,
the
right?
opposite direction.
For Q.
Makes perfect
Is
sense,
that right?
but I'm not entirely sure. Thank you.
Hmm.
13. So, do you see cues? If so, where? And are they signs of old stuff or new stuff?
Ooh, I'm gonna say, what was the question again?
What was the question?
Old. That's what I'm gonna go with.
Where do you see cues?
Maybe over in this section?
Be specific.
It's the Q's everywhere, bro.
I'll be honest, I had trouble with this one, I just.
Okay, well, that's
Okay,
perfect,
so
then we'll work
These
on
ones look pretty big, pretty
Yep.
long.
it. Let's go through it, excuse me.
Yeah. that
Let's go
does.
through it. Do you see any cues here?
No.
Okay, what about here?
Uh,
There's cues.
yeah.
Absolutely.
Okay.
Yeah, because remember, if a QRS, if it's just one negative deflection, we think of it as a Q.
Okay.
Okay? And would you call this based on our, remember we had that, oh, there's 3 different criteria, it only needs to fit one.
Yeah.
Would you call those pathologic?
Yeah, I think it's more than one box, right?
It's more than one box, and also the entire, when you have a situation where the entire QRS is made up of a Q wave, all it has to be actually is 25% of the QRS. In this case, it's 100% of the QRS.
Right.
So you're home, you just look at it and go, oh yeah, it's pathologic. Okay, so yes, what about this one?
I'm gonna say yes as well.
Okay. Okay, we're not worried about AVR, what about AVL?
No.
Okay, what about AVF?
Yes.
Okay, V1,
Yeah.
2, V2?
Yes. Yes.
Yeah, so this whole section, as you said. Okay, so V1 through V6. So, the question is, we know, you're only like partway down here, is that we know that pathologic cues either mean something old or they're associated with something acute.
Yeah.
So in this case, which one is it?
I'm gonna say old.
Okay, and I agree with that because there's no signs of acute ischemia here, right? Nothing that we've learned so far. So the question is, if all these pathologic cues are a sign of old MIs, where were those old MIs located?
Yeah, it seems like they might have been everywhere.
Inferior.
Yeah, lateral septal and anterior.
Yeah, okay. So, Q's 2, 3 AVF, V1 through V6, no signs of acute stuff, so possible old inferior septal anterior lateral. Yes?
Do you have to have it in 2 continuous boxes to count?
Yes.
Yes.
Yeah, pretty much.
Okay.
Yeah. Okay. Who's next?
Me. Okay, I thought this one was hard, but I'm gonna talk my way through it.
Okay.
So one, it looks like a little bit of elevation maybe.
Okay.
2 is depression. 3 is depression.
Let's look at V2.
Yeah.
Okay.
Oh,
So
this
it's a
is-
very weird QRS, no question. But the J point is actually here. What we have is a Q, almost an R wave, because it should come up to the isoelectric, and then an S. It's very strange looking.
Okay.
So, or else we could even, let's just call it a QS wave and leave it at that and not worry about exactly which one it is. But
Okay. So then 2 is elevated, 3 is elevated,
Mhm.
4 is elevated, 5 is not.
Okay.
6 is not.
yeah, maybe, yeah, hard to say because this looks so different from here. Okay, so do you have Q waves?
There are Q waves.
Where?
yes.
Pathologic Qs. maybe.
I don't think this counts as 25%, but it's hard.
It
to
doesn't, but if you look at it, it's hard to read these ones. But if you look at it, is there one small box between here and here?
I think so. So then
Uh-huh.
it would be pathologic.
And also, is that Q wave at least 2 small boxes deep?
Yes.
Yeah. Pathologic Q. Okay. What about here?
Yeah, it's at least
Mhm.
2 small deep.
Yep. And then what about here?
Yes.
Okay. And then,
Here,
actually, no, because
That's a
if you look
R.
at the one good one, there is an R.
RS.
Okay.
And same here. Let's see that.
Okay, so where do you summarize that by telling me where you see the Q waves?
I see them in V1, V2, and V3.
So do you think they're associated with old stuff or acute stuff?
Acute, since we have the ST elevation as well.
Mm-hmm. Absolutely.
So it's
Q's in V1 through V4. I disagree with V4. That's wrong. That should be changed to V3. Okay, wrong. ST elevation. So these Q's are probably part of an ongoing septal anterior STEMI. Okay. Okay. Who's next?
So I said dump elevation in none in 1,
Mm-hmm.
and then 2 and 3,
Okay.
and then right there. And
Okay.
then I have a question, because this is my Q. It's right, it's taking up more than 25%, but it's AVR. So is it, oh yeah, that one too, but if it was only.
Let's just not worry about AVR until we
Okay,
worry about
perfect.
AVR.
So I'm gonna say it's an active inferior MI.
Okay, and tell me again before we get into the, what's your evidence right now of the active inferior?
Because we have ST elevation in 2, 3, and
Okay, and what else?
and then the Q in 3.
Okay, and also AVF, I would call that. Okay, so Q's in 3 and AVF, and there's other evidence of that inferior setting. What is it? So you've got ST elevation, you've got.
Reciprocal.
Yep, reciprocal changes. Yeah, and I can't reach it, but I actually think if you, even though you said there was, your second time round, you said there was ST elevation in 2, which I agree with. Your first time around, you said there's not, and I just want to point out, if you take your straight edge and lay it along the isoelectric line, I think there's about 1 there. So you don't need it because you've got this and this, but I'm just being picky here. Okay. Oh, in fact, yeah, okay, there we go. Okay, next one, please.
16, I think, is a age-related, and I believe it's inferior.
Okay, so where are you seeing the Q's?
In 3,
Uh-huh,
and, as well as EVF.
correct.
Yep.
And any signs of acute stuff?
No, I don't see.
No, I don't either. Okay. Okay, and one last one here.
So, Q, V2, V3, V4, V5, V6, and then I got ST elevation in V2, V3, V4, V6. I think it's a current septal anterior lateral.
Okay, and the Q's are part of that.
Correct.
Correct, okay, I think that's what you said, yeah. Okay. Okay, this is one of these not, so I'm just going to put, if all you see are Q waves in 3, just 3, okay, that could be a normal variant, okay. Now there was one in there where there was a huge Q wave in 3, and I would think that one actually is pathologic. But if all you see it in 3, not in AVF, not in 2, it might be a normal variant. I'm not too worked up about if you remember this. This is just one of these niggling details that after a while you start sort of saying, oh yeah, 3 is a little bit different, okay? So here's what we're going to do. That's as far as we're going today with the lecture. Next week, we are going to do right side and posterior. It doesn't take too long. But we're going to do one more short thing today. I printed out your homework, okay? And
Do it this time.
let's just pass it out. And I want to show you how to do it, okay? And the answers are, even though I printed it out, you'll have to look on Canvas for the answers,
The answers are close to the new thing.
okay?
Yeah, we did that unison, sweetie. Next to it. Oh, wait, I can talk about that.
We're not doing EKG next week, right? When you could,
Week after, yep. Okay. Okay, hey, so everybody turn to number 2, because that's an easier one to explain than number 1, okay, even though you're all gonna do it the same. This is how you'll be doing it on your quiz when it happens, which starts on the 8th. And it's kind of the way I'd like you to think about a 12 lead, okay? So we're going to go through this together, and you can write down the answers, but I would save it. I would write them on the side, or just make sure you understand it, so that you can, when you do it, then you have another practice problem. So don't wreck this practice problem for yourself, if that makes sense, by putting the answers on it. Okay, so first of all, when you start this homework, and there's 15 problems, the first thing I want you to go through is what I said. Go lead 1, lead 2, lead 3, ABL, ABF, V1 through V6, and just circle each lead, at least this is the way I do it, and write down a D if it's depression, and E if there's nothing, or just leave it blank. So before, even one like this, which clearly sort of jumps off the page at you, be systematic at the beginning and look for depression and elevation. That's a really good habit to get into. Don't just jump to the bad stuff, okay? So then what I want you to do is to start organizing the evidence in your mind. So, for example, figure out where you have ST elevation in 2 or more contiguous leads. So in this case, I'm just going to start we have V2, V3, V4, V5, V6, okay? So let's just look at that side for the moment. So based on that, what kind of infarct are we ending up with? What kind of STEMI? What areas?
Septal.
Yeah, septal anterior lateral. So then what I want you to do, let's see, do I have the answers here? Yeah. So what I want you to do then is write down, this is what you do, write down septal anterior lateral, okay? That's your areas. The first bit of evidence with a STEMI is always where's the ST elevation, okay? So in this column, you write septal. Well, which septal lead? Well, V2, so you write that. Which anterior leads? V3, V4, lateral, all the lateral leads, so write them down, okay? Straightforward so far? Then I want you to look and say, is there any additional evidence? You have 3 options of additional evidence. You have reciprocal changes, you have hyperacute T's, and you have pathologic Q's, okay? And I'm completely okay when you get to your quiz if you use, this is what I use. You don't have to, you can write it down if you want. I just write RCs for reciprocal changes, HTs for hyperacute T, and capital Q for Q's, okay? You don't have to, you can write it out, but if you want to make it easier on yourself, you can do that. Then I want you to say where it is. So is there any additional evidence besides the ST elevation in V2 for the septal? Nope. There's no hyperacute T's. Reciprocal changes aren't applicable for V2, and there's no Q waves. This is blank. V3 and V4, oh yeah, look, from the J point, these are hyperacute T's. So you could just write HTs if you want and say where it is. HTs in V3 and V4, okay? And then the lateral, we've got the reciprocal changes in 3 and AVF, okay? Well, that makes sense? So I really like this idea of thinking in terms of evidence for the infarcts. Yeah?
Lead 3 was really throwing me off, so it's like plateaus at the top. Is that our isoelectric line?
Yes, so there's a, here's the beginning of the QRS loop. Possibly that's an R wave, not sure. This is either an S or a Q wave. The J point is here, there's a flipped T, and here's the TP segment. So this is where I would lay my straight edge.
Okay.
Okay? Okay, identify the rhythm, and again, as paramedics, we don't do it in the field, but I want you to practice getting the rhythm from just a 12 lead with no rhythm strip on the bottom, and the only reason I'm asking you to do that is you may be asked to do it in the National Registry. I don't know that for sure, but just good practice. And that's pretty easy, it's just normal sinus rhythm, okay? You can figure that out. Are there any signs of old infarctions? Meaning, are there any Q waves that are not associated with acute ischemia? Okay, when you see my answers that are in parentheses, that means I'm okay with it being there, I'm okay with it not being there. You could make the argument that this is actually a Q wave. Yeah, so possibly there's an old inferior, but that's a little squishy. And you don't have to worry about this for now. By next week you'll know. I can tell you what the answer is. If there's an inferior STEMI, you write yes. If there's no inferior STEMI, you write no. But you don't have to do that right now, okay? So, questions? Excuse me again. There may be something in here about posterior. If you get to that, don't worry about it. We'll do it next week. And we will review these next week. We'll start off by reviewing these. Or 2 weeks, I guess. Yeah.
I said it, but I missed it. When's this homework due?
Well, it's, you don't have to hand in anything. It's all self-check. So it's up to you, really. But have it done, if you're going to do it, which I assume you will, because it's much to your benefit, then do it before the next class, which I believe is on the 7th.
7? Okay.
Yeah.
With on me.